This is Charles Clinton from the Heart of Medicine, and this video right here is as I prepare for the ABIM certification test. So today is May 19th, 2025, and I'm studying for this test before I go into cardiology. And the reason for this video is to share it with you in case you are working on internal medicine, learning internal medicine, preparing for the test, anything that might help while you're washing dishes, walking the dog, etc. Because I don't see any of these videos online, or very few of them. So it would have been nice to see more of those in the past. So we're just gonna review the pearls I learned from this test I just took till my wife gets home. So the goal is till the dogs start barking, because that means that wife is home. So let's start off with which pearls we have here. So, okay, first of all, let's start off with primary biliary cholangitis. Remember that it primarily affects women aged 30 to 65, and I had a mnemonic for this, but it was in Spanish, so it won't make much sense in English. I'll just say it in Spanish if there's any Spanish speaker here, and then move on. So it was Elmita toma guaro dentro de la casa, something like that. So it means Elmita is the name of the lady, saying that she drank alcohol inside of the house. So basically that was primary biliary cirrhosis, meaning that it was intrahepatic inside the house. Alcohol, the cirrhosis part of the name, and Elmita is mitochondrial antibody. But in English, of course, that mnemonic won't work that well. But yes, so the typical pattern is going to be a cholestatic pattern injury. So that's what you're going to have. You're going to have, let's see, anti-mitochondrial antibodies. Up to 50% of the patients also develop metabolic bone disease. So this is the main pearl I learned from here, is that primary biliary cholangitis is associated with bone problems and osteoporosis. In this case, they were asking me, they told me the whole picture for the patient, and they asked me what's the highest, or this patient is at highest risk to develop what. So I wasn't sure what exactly, so I didn't get it right, and the answer was osteoporosis. What other complications do you have from primary biliary cholangitis? You can have fat-soluble vitamin malabsorption. So fat-soluble vitamins are A, D, E, and K. We already talked about the bone, and hepatocellular carcinoma. That's it for that one. Let's go on to the next one. So the next one is a patient. They're telling us that potentially has some liver problems, has hepatic encephalopathy, just was started for SBP, so spontaneous bacterial peritonitis, and was started on treatment for that within, let's see, just was started on it, and had gradual improvement on the treatment, but the serum creatinine increased from 0.9 at admission to now 2.1. So now you're having acute kidney injury, and the urine output during the past 24 hours is 450 mLs. No history of kidney disease or other problems, and the patient had been on home diuretic therapy with furosemide and spironolactone that had been initially continued during hospitalization but stopped yesterday. So what they're asking us in the question basically is, which of the following is the most appropriate next step in management of the patient's renal dysfunction? So you have different options. I'll read them to you. One is antibiotic discontinuation. Another is intravenous albumin infusion. Option C is large volume paracentesis. Option D is restarting diuretics. And option E is transjugular intrahepatic portosystemic shunt. So immediately I crossed out the TIPS procedure, transjugular intrahepatic portosystemic shunt. This is the first time this happens to this patient. It's way too invasive at this time. Next thing I ruled out was large volume paracentesis, because the patient has a soft, non-tender abdomen, moderate ascites. So nothing that's telling you, oh, we have to take this fluid out right now. And I was between restarting diuretics and intravenous albumin infusion. And I was on the fence, because I was thinking of the diuretics improving, or the holding of the diuretics being associated with the patient now sort of peeing 450 cc. So I thought that maybe holding the diuretics was worsening the patient. So I was thinking maybe restart the diuretics. But the main thing here was to coin the idea that when you have a patient with SBP, of course, they are a kidney injury. Now you have a very high risk of this patient developing hepatorenal syndrome. The way you ruled out hepatorenal syndrome is by, first of all, holding the diuretics, which they had done, but they were missing something, and they were missing to do the other thing, which is administer intravenous albumin. So those two things together are the ones that will tell you this patient has HRS or no. Remember, HRS is, or hepatorenal syndrome, is a diagnosis of exclusion. So if the patient has improvement on the fluids, it means that this patient was probably it wasn't HRS. But if there is no improvement despite holding diuretics and giving IV fluids, that means the patient has HRS, and the treatment will be the vasoconstrictors. If the patient is in the outpatient setting, you will probably do midodrine, or maybe do octreotide even, in the hospital. Yeah, you shouldn't have a patient with HRS outpatient. So if the patient is not in the ICU, midodrine or octreotide. But if the patient is in the ICU, or you can give norepinephrine IV, it's going to be norepinephrine, because it will take the place of the midodrine, right? Okay, management, we already talked about it. And the definitive treatment is going to be liver transplantation. And what else can we talk about? Remember that fractional excretion of sodium will be less than 1% in hepatorenal syndrome. So it might look like a patient that has pre-renal AKI, right? So that's about it for that one. Pathophysiology, maybe let's just mention real quick. HRS, let's see what it is. So basically what happens with HRS is that there's splanchnic dilation of the vessel. Since there's splanchnic dilation, there's not enough flow to the kidneys. The kidneys are sensing they're not receiving enough blood supply, so they will just contract, and that will make them not filter much, and they will go into acute kidney injury. So that's why you have to vasoconstrict the splanchnic circulation with the medications I just mentioned. Okay, so now let's go on to the next one. Okay, that was about it for that one. And next question is a patient that is 36-year-old female. She knows she's had these little vesicles along the lip border in the past. It starts tingling and burning before she gets the lesions. And she approximately gets this every 1 to 2 times per year. So the question is, which is the best next step in management of the patient? So the idea is to avoid this from getting worse, and what is the best treatment? So I'm just gonna read you the most difficult options to pick from. One says oral valacyclovir at the onset of symptoms, and another one is symptomatic treatment at the onset of symptoms, and the last one will be topical acyclovir at the onset of symptoms. So those three are quite difficult options to pick from. You might hear the dog snoring in the background. That's our oldest dog, which is deeply asleep. So the clinical pearl here is oral valacyclovir or oral antivirals is what you want to give at the onset of symptoms. You don't go with the topical. You might do topical if necessary on top of it, but what you want to do is the oral. So you can do different oral antivirals, such as acyclovir, famciclovir, or valacyclovir. And you do this as soon as the symptoms start. So that's going to be before you have the actual vesicles seen in the borders of the lips. And you can also do chronic suppressive therapy, which is daily acyclovir or valacyclovir. Of course, it's not going to be recommended in patients that have a lot of episodes of this, more than 4 per year, painful or disfiguring lesions without a prodrome, or herpes simplex virus recurrences with complications such as aseptic meningitis. Let's go on to the next question. This next question is basically asking us what to do. They're showing us a photograph of how the arm looks. They're showing us a rash in the arm. And I'm going to show you very briefly that rash in the arm so you can see it right over here. That is the rash in the arm, okay? And they're just showing us this rash right here. And they're giving us all this information that he is a firefighter, but if you read all of this, it's not adding much, to be honest. It's just showing you this rash. So the main question here is, which of the following best initial treatment for that patient's condition? So focus on the rash. If you see the image, just think, okay, what can this be? What should I give it? So I'll read you the options. Option A, it says antifungal therapy. Option B, antiviral therapy. Option C, corticosteroids. D is penicillin, and E is permethrin. I didn't even waste time with permethrin. This isn't any infestation. This is not any parasite on the skin. Doesn't look like it. This doesn't look like anything penicillin will treat. This doesn't look like anything viral. The only one I was having hesitation with was between antifungal and corticosteroid. So why was I thinking maybe about antifungal? Because I was thinking that maybe this could be, since you could see sort of a line, I thought it was sort of a line, that this could maybe be sporotrichosis, which is generated by Sporothrix schenki or skanky or I don't know how to pronounce it well. But that's not sporotrichosis. It would be even clearer, and I'm trying to show you a picture of it. And they would probably give you more clues. So I'm going to show you maybe sporotrichosis. Just remember that with sporotrichosis, you're going to have nodules. It's more nodular than what you're seeing over here. So what you're actually seeing over here is called poison ivy. So it's a hypersensitivity reaction type 4, which is a cellular mediated, and this is poison ivy dermatitis. So you won't see this within an hour of exposure. This might appear later on, 8, 12, sometimes even 24 hours later, because it's cellular mediated. And the treatment for that is going to be the corticosteroids. And just so we can see the elemental lesions here, there's a bulla here, there's erythematous papules and vesicles with linear or streaking arrangement. So okay, yeah, it was also poison ivy. It was something associated with plants, not specifically sporotrichosis. Okay. And actually, the question stem doesn't even mention, if you go to the section where it explains why not antifungal, it's talking about tinea pedis or tinnias. So they didn't even think about sporotrichosis. Maybe we could reach out to whoever made this question, give them feedback that maybe this choice with antifungals would make more sense, that a differential was sporotrichosis, because definitely a tinea doesn't look at all like that. It would be, yeah. So okay, that's about it. That's the learning pearl here. And treatment should be continued for 2 to 3 weeks if you have poison ivy or poison oak contact dermatitis. So those are, let's see, which questions are those? We're going on to those were maybe incorrect questions, I think. Now we're gonna see the other questions, and let's go quicker. So we still have some pearls to talk about. So we have a patient here, 24-year-old woman, which had a positive, let's see what she had a sexual partner. She wasn't using condoms consistently, was also having symptoms, so mucopurulent cervical discharge and cervical friability. A NAT or nucleic acid amplification test was positive for chlamydia trachomatis. So the patient was treated. Doxycycline was given for 7 days, twice daily, and the patient's symptoms resolved after a week. And the patient mentions no sexual activity since then and is currently asymptomatic. But apparently, the patient has a new NAT, which is positive for chlamydia. So a pap test is normal and a NAT is positive for chlamydia. So they're asking us what is the most likely explanation for the patient's positive test result. So the clinical pearl here is that a NAT, nucleic acid amplification test, is it's the most sensitive thing there is out there for many, many infections, of course. But in this case, for chlamydia, it's also the most sensitive thing. So it will detect the bacteria when it's alive, and it can also detect it dead. So maybe the bacteria was dead a while ago, but it's still detecting it. So that's why it is not recommended to do post-treatment or to check for a curative test, because you only test for cure with in pregnant women. Why? Because the risk of not catching this outweighs any benefit of not checking it. So in pregnancy, yes, you check after 3 weeks or 3 weeks after treatment. If the patient is not pregnant, you do not test for cure. You test for reinfection. So you do assume that the patient was cured because the resistance pattern for chlamydia, trachomatis, for the first line antibiotics, azithromycin or doxycycline, is very, very low, meaning that you would assume that after an adequate course of antibiotics, it was cured. And you can test for reinfection in 3 to 6 months. Why 3 to 6 months? Because it makes sense. If it's positive, okay, it's not a false negative because you've given false positive because you've given it enough time. That was the learning pearl for that one. So now let's see another question. This is a 79-year-old man, and it's telling us that this patient is having fatigue, weakness, frequent muscle cramps without shortness of breath. The patient has a whole lot of cardiovascular comorbidities, is on carvedilol, lisinopril, furosemide, and lansoprazole. And clinical examination isn't that abnormal, with exception for neuromuscular. There you can see that there is mildly increased reflexes and no muscle tenderness. And then they give you some labs, which are basically normal. So the question is, which of the following is the best next step in evaluating this patient's symptoms? Option A, arterial Doppler. Option B, magnesium level. Option C, parathyroid hormone level. D is serum creatine kinase. And option E is serum iron and ferritin levels. So maybe I didn't provide you with all the information. You might need to answer the question or to rule out other options, but I gave you all the information needed for you to think of one that stands out here. And the main one is magnesium level. Why? Because magnesium is the only option here that can be associated with hyperreflexia. So yes, you can have the weakness, but you're going to have hyperreflexia. That's what happens with magnesium. So don't forget about magnesium. And the way they're setting this up in this question is that proton pump inhibitors can alter the absorption of magnesium in your gut. So it reduces the absorption, so you can have hypomagnesemia. And how is that even worsened off? Or, yeah, it's worsened off with diuretics. So you add a diuretic plus a PPI, check for magnesium. Actually, the recommendation is that people with PPIs should get their magnesium checked before starting treatment and at certain moments post-treatment with a PPI, just to make sure they're not going hypomagnesemic. So that's the main pearl here. And what other things are associated with hypomagnesemia? Well, we did mention fatigue, weakness, neuromuscular hyperexcitability. What cardiovascular abnormalities? You can have QRS widening, hypocalcemia, hypokalemia, and metabolic alkalosis. Okay, so that's about it for that one. Let's go to the next one. This other question is very interesting, and this is a good point because this is a 35-year-old female. She has a history of relapsing remitting multiple sclerosis. And what were her neurological findings? It was that her left lower extremity was weak. And basically what's happening now is that she is febrile and she's having a urinary tract infection, and her neurological exam shows weakness and spasticity of the left lower extremity with hyperreflexia and extensor plantar reflexes. So they're basically asking you, what should we do next in addition to the treatment of the urinary tract infection? So one option is repeat a brain MRI, brain and spine MRI with gadolinium. Another one is change of the disease modifying therapy. Option C is intravenous high-dose methylprednisolone, and option D is no additional intervention necessary. So this I might call would be high value care, which is using resources appropriately. So actually, yes, probably you're thinking about the answer now that I mentioned high value care, which is less is more. So, or choosing the least costly medication or diagnostic modality, which will end up with the same results or which has the same output as the more expensive. So the answer is no additional intervention is necessary. Why is this? Because multiple sclerosis can have pseudo relapses, and a pseudo relapse just means that any symptoms the patient already had worsens if the patient is infected or has acute illness. So there's a worsening of those prior symptoms with infection or heat. So also be aware that some of these patients, if they're in the heat, they might have worsening symptoms. Maybe they don't need to change treatment, they just need to cool down. So that's it. So if the patient actually had a relapse, you would see that the patient would not be infected, would probably not have a fever. The neurological symptoms probably are new and not the same old things the patient had, only that worse. and in a new relapse, high-dose glucocorticoids would make sense. Okay, that's the clinical pearl for that one. Let's go on to the next one. So this one is a 79-year-old woman. She's being evaluated. She's going to get a cataract surgery, and she's also on warfarin. Her INR was 2.5 about 2 weeks ago. Why was she on warfarin? We probably don't care, but okay, it says it was because of non-valvular atrial fibrillation, okay? And she's also on lisinopril, furosemide, carvedilol, and amlodipine. So what they're asking here is, what is the best way to manage this patient's anticoagulation? So they're asking you preoperative management of anticoagulation in a patient that's going to get a cataract surgery. So probably this is something that has taken me some time to learn in my brain, which is that not every surgery that involves the eyes, just because it's the eye doesn't mean it's going to bleed a whole lot. So I finally understood and learned that cataract surgery is one of those things that you'll see on every single table, that is a very low bleeding risk. So you have a very low bleeding risk procedure. The patient is anticoagulated for a clear indication, has to be anticoagulated. So do you just stop the warfarin? Do you hold the warfarin? Do you bridge the warfarin? So the clinical pearl here is you continue warfarin with no change in dosing or target INR. So that's the main pearl. And how can you divide perioperative bleeding risk? So you have high risk procedures or surgeries. How is that defined? That's going to be a 2-day risk of over 2%. That's high risk bleeding. Usually 2 to 4%, that's high risk procedure. How do you know what's low risk? Well, anything that is less than or equal to 2% bleeding risk in 2 days, right? And now, which ones are low bleeding risk? Okay, cataract surgery, tooth extraction, CVC removal, pacemaker or ICD placement, lymph node biopsy, endoscopy without needle biopsy, and carpal tunnel repair. So it seems that dogs maybe are detecting mommy is on the way. High risk procedures. You have cardiac, vascular, neurosurgical, intra-abdominal, urologic, joint replacement, laminectomy, renal biopsy, and endoscopy with fine needle aspiration. Okay, so now let's see, maybe one more. I'm gonna end with this one, and this one is one that I'm sure most of you haven't heard of. So this is a patient that has a pleural effusion on both sides, has some symptoms concerning for potential heart failure, and has the light criteria. So they give you the labs. This is the total protein, this is the albumin, this is the lactate dehydrogenase. You have it all to decide if this is effusion or transudate. And the question they're asking you is, what is the likely cause of the pleural effusion? And this is where it gets tricky, because this patient I calculated the different parameters, and there was no total protein, or the protein in serum to the effusion was normal. It was less than 0.5. So it wasn't an exudate, it was a transudate, but there's other criteria. So the LDH criteria, it was 60. 60 is not 2/3 the upper limit of normal, so it doesn't have that one. But when you divide it, D is the quantity of the lactated dehydrogenase in the pericard pleural space compared to the total lactated dehydrogenase in the body, it gave me 0.64. And I'm like, oh man, it's barely above 0.6. So I wanted to say this wasn't an exudate, but you know that only one criteria of light that is positive, it's an exudate. So I'm like, this is an exudate. So I didn't know what to answer, because congestive heart failure was what everything was pointing towards, but it was an exudate, and that wouldn't go hand in hand, at least in the exam. So I didn't know something, and I didn't know that this patient was on diuretics, and that patients that are on diuretics with heart failure can get a false manifestation, a false read of exudative effusion, when in reality the patient has a transudate. And how does that happen? Well, let's see. I probably won't give you right now the exact reason for it, but I'll tell you how you can distinguish one from the other, which is, if you have something that looks like a transudate heart failure transudate, but it's giving you numbers in the light criteria, okay, you then go and do an additional math equation, which is you subtract the total serum protein minus the total effusion protein, and if that gives you more than 3.1, you're talking about a transudate. The other option is doing the same with albumin. If you subtract the total serum albumin from the total effusion albumin and it gives you more than 1.2, it's still suggesting you a true transudative effusion. So that's it. This patient, in the end, when you did this extra math problem, it gives you transudate, so it was a heart failure situation. And that's it for this one. See you on the next one. Hope you liked it. Give me feedback, like, dislike, etc. See you later.